Welcome to The Explainer. Today, we're tackling a really serious pregnancy complication called placental abruption. We're going to break down exactly what it is, why it's so incredibly hard to diagnose, and how doctors have to manage this high-stakes emergency.
So to really get a sense of why this is such a big deal, let's start with a number: 11%. In the United States, hemorrhage, or severe bleeding, is responsible for over 11% of all pregnancy-related deaths. And when that bleeding happens before the baby is born, placental abruption is one of the very first and most serious things doctors have to consider.
All right, so let's get right into it. What exactly is placental abruption, and what makes it one of the most frightening complications you can face during a pregnancy? Okay, so at its most basic, it's a premature separation. Think of the placenta as the baby's entire life support system. It provides all the oxygen, all the nutrients. It's the vital link. When it starts to pull away from the uterine wall before delivery, even just a little bit, it causes bleeding and starts to cut off that crucial lifeline.
Now, you might hear that it only happens in less than 1% of all pregnancies and think, oh, that's rare. But, and this is a huge but, its impact is just staggering. Placental abruption is linked to a full one-third of all perinatal deaths. That single statistic really drives home just how severe this is.
So, the big question is, what actually causes this to happen? And honestly, this is where things get a bit murky. Researchers have found more than 50 different risk factors, but a lot of the time, the specific trigger is a complete mystery. Let's look at some of the main culprits.
I mean, the list is all over the place. Some risks are tied to lifestyle choices, like smoking or cocaine use, which can damage the delicate blood vessels in the placenta. Then you have pre-existing health issues, like chronic high blood pressure. Other factors include being older or having had several babies before, which is called multiparity. And sometimes it's triggered by an acute event, like a car accident.
But here's the thing you absolutely have to remember. While all those factors are in play, the single greatest predictor is having had one before. If a woman has had a placental abruption, her risk in the next pregnancy skyrockets. We're talking a 10-fold increase. That is just a massive, massive jump.
Okay, so with all this complexity in mind, let's talk about the next huge hurdle: actually diagnosing it in time.
This quote really gets to the heart of the problem. A clinical diagnosis means there's no magic blood test or scan that gives you a simple yes or no. Doctors have to be detectives, piecing together clues from symptoms that can look wildly different from patient to patient. Sure, bleeding and pain are the classic signs, but you don't always see them.
And this chart really lays out the puzzle for you. Imagine you're a doctor, and a patient comes in with bleeding late in pregnancy. Your mind is racing through the possibilities. Is it abruption with its typical pain and bleeding? Or could it be placenta previa, which often has painless bleeding? Maybe it's just the start of labor. Or worst case scenario, a catastrophic uterine rupture. Each path requires a totally different and urgent response. Now, sometimes an ultrasound can give you a pretty big clue. See this image? That dark spot there is what's called a retroplacental hematoma, basically a pocket of blood that's collected behind the placenta. If you see that, you're pretty sure you're dealing with an abruption. But, and this is a critical but, you cannot rely on an ultrasound to rule out an abruption. Just look at that sensitivity, 15 to 35%. That means it misses the vast majority of cases. So a clear ultrasound doesn't mean everything's okay, not by a long shot. It all comes down to the experience and clinical judgment of the medical team.
So, given how tough this is to diagnose, what happens next? Once it's suspected or confirmed, how do doctors and nurses actually manage this emergency? You'd think for something this serious there'd be a standard playbook, right? Well, you'd be wrong. There's actually no one-size-fits-all treatment protocol. It's pretty wild, but there have never been any randomized controlled trials on how to best treat it. This means that every single case has to be managed individually, based on the baby's age and how stable both mom and baby are.
And the biggest factor in that decision is gestational age. If you're near the finish line, past 34 weeks, the solution is usually clear. It's time to deliver the baby. But if it's earlier, say between 24 and 34 weeks, it becomes this incredibly delicate balancing act. You want to give the baby's lungs more time to mature with steroids, but you can only do that if everyone is perfectly stable.
But when things do become unstable, especially if the baby's heart rate suddenly drops, which is called bradycardia, then it is an absolute race against the clock. The data is crystal clear on this. Performing an emergency C-section within 20 minutes of detecting that distress leads to much better outcomes than waiting even 30 minutes. Every single minute counts.
All right, let's pull all of this together. What are the key things to remember about placental abruption, and where do we even go from here?
So to recap, we know placental abruption is a top cause of dangerous bleeding late in pregnancy. We don't really know what causes it, which makes it incredibly hard to prevent. Diagnosing it is a massive challenge because the symptoms can be all over the map and our imaging tools just aren't reliable enough. And managing it? Well, that's a high-stakes balancing act that relies on constant monitoring and quick, individualized decisions.
And that really leaves us with the ultimate question, doesn't it? Right now, we're mostly playing defense, reacting to this emergency after it's already started. But the real hope, as science moves forward, is to get ahead of it. Can we one day develop the tools to accurately predict who is at the highest risk and maybe, just maybe, intervene to prevent this from ever happening in the first place?